Hi, good afternoon and welcome to another edition of the Dynamic Editorial for the JACC Cardiovascular Imaging. My name is Dr. Chandrasekhar and I am one of the Associate Editors for the JACC Cardiovascular Imaging. It's my pleasure today to have two of the greatest minds in valvular heart disease in this country, Dr. Maurice Serrano from the Mayo Clinic in Rochester, Minnesota, and Dr. Blaise Carabello from the Houston VA and the Baylor College of Medicine. Dr. Serrano, you have an upcoming article in the JACC Cardiovascular Imaging about quantifying aortic regurgitation and correlating with prognosis. Why do you think it's a area that we should concentrate on, and tell us a little about your paper?
Thank you. Thank you for taking the paper. Thank you for giving us the opportunity to discuss this issue. As you know, in the early 1990s, methods were developed by Doppler echocardiography to quantify regurgitation. But up to now, we didn't know the outcome implications of that and how they should be used in clinical practice and how they should influence the established indication for those patients. So in this study, we gathered a group of 251 patients asymptomatic with aortic regurgitation of any degrees, and we looked at the implication of the quantified measures on the long-term outcome. And what we saw is that, as expected, the quantitation of aortic regurgitation predicted the outcome. But interestingly, that the measures, the quantitative measures, superseded the qualitative assessment of aortic regurgitation. In addition, what we saw is that they superseded the diameters measurement and of the LV, the left ventricular diameters, and they were associated with the end-systolic left ventricular volume in predicting the occurrence of cardiac events. Finally, one of the results we had were that the people that were at the highest risk, that is the people with what the American Society of Echo calls severe aortic regurgitation, when they were operated, benefited from a reduction in cardiovascular events, substantial and significant, so that not only are we capable of identifying people at risk, but we're now capable of treating them and reducing their risk of events. So we believe that it's a tool that has come to age, should be distributed in the cardiovascular center and used widely in patients with aortic regurgitation.
Dr. Carabello, you're coming out with an editorial on this. Why did you like the paper, and what do you think it shows which we already don't know?
I was very supportive of this work. The title of the editorial was Cardiologists. Do we have the right to call ourselves physiologists? Physiologists are people that see how things work, and in order to measure how things work, you need to have accurate tools. If one of us were to buy an expensive suit, you would never expect a tailor to say, that's a small, medium, or large, and expect that was the outcome of his tailoring. You'd expect very precise measurements. And now we're talking about someone's heart. We should expect at least the kind of measurements from our cardiologist that we expect from our tailor. And this helps to provide that.
You make a good point, but either of you would like to comment on how much time does it add? I mean, in a busy lab, you might say, I have other methods which are equally good at approximating the severity, and this adds a lot of time. And can a lab routinely afford to add this to their?
That's a very good question of saying, is it realistic? Well, we make it realistic in our practice. That is, the people that we see with valvular heart disease, we believe we have to quantify that. It's done in a routine manner. The sonographers are instructed, the physicians are aware and capable of doing the extra measurements. And we believe it's very important in managing the patients directly. So it is not, should we do it? I believe we should do it. It's for people to learn the tricks, and what is very encouraging is when you go to echo meetings, you see that more and more hands are raised and saying, can you do it? Do you do it in your routine practice? More people are saying, yes, despite the pressure on the activity, people are measuring it.
How much does it add to the time of a study?
Probably 5 to 10 minutes to the study to get the results properly, at least with one good method applied. So it is not an enormous and unsurmountable effort.
Dr. Carabello, What's your take on this? Are we now moving to measure everything, including mitral regurg, aortic
Well, and of course, Dr. Serrano has already demonstrated the benefit of measuring mitral regurgitation. Obviously, there are obvious cases that don't need this level of precision, but they should be in our armamentarium for making close calls. The question is how much time does it cost, or can we afford to make a mistake about when to operate on someone's aortic valve? And I think there are times when we need these tools to help us answer that question.
Do you think we need to think about using mortality to show a benefit of this extra effort, or are we diluting it by using time to surgery or how many people get operated as a factor which makes it look better than it is?
I think in general, the whole area of valvular heart disease suffers from the lack of trials against anything. And we certainly need more data, but it has to be a basic tenet that measuring things accurately is a good idea, and that clearly in some cases it provides benefit to the patient to be able to tell him or her how much aortic regurgitation they have and whether or not that's likely to require surgery in the near term.
This is like Lord Kelvin about 100 years ago. He said if you can't measure it, you can't improve it. So maybe
right.
we are reaching that.
That's right.
We have about a minute, and do you want to summarize where we are going in this area of quantitation?
You know, the surgeons have improved the surgery, even though the prostheses haven't changed recently, the mortality has decreased. So we have to adapt our treatment. And you can only put guidelines for things that are measured and the outcome is analyzed. So when you look at previous guidelines on operating for AR, there were a number of people that would not be normally operated, that with these new criteria, and we hope to bring other criteria to we can now define smaller subgroups at higher risk that can benefit from the operation. And I think we have to continuously do that work of improvement in our understanding of the physiology, of the outcome, to provide the best outcome to our patients.
Anything you would like to add, Dr. Carabello?
We cardiologists owe our patients the very best that we can give them, irrespective of the pressures of the day. And most of the time, quantitative, or much of the time, qualitative assessments are fine. But we need to have these tools available to us to help make the close calls. If you don't practice the tools, you won't know how to use them.
So if I summarize, both of you are saying that in a year or two, this is an absolutely essential thing for every lab to invoke.
Absolutely.
Thank you very much. That was a very useful discussion.